Pharmacotherapy of Constipation. So what do you mean by constipation? Constipation is basically a functional gastrointestinal disorder or functional bowel disorder. It was described by different types of the criteria. The most common is the Rome 4 criteria, the latest one. According to this Rome 4 criteria, the chronic constipation can be described when the defecation rate or frequency is less than 3 per week, and associated with this different other symptoms like straining, hard stool or difficulty in defecation. All these, if this is present for a long period of time, particularly approximately 3 months, then it can be categorized as constipation. Now this constipation, you can easily understood that this can be primary or secondary. Primary constipation is also known as the chronic idiopathic constipation. Okay, chronic idiopathic constipation. Now this chronic idiopathic constipation can again be differentiated into normal transit constipation, slow transit constipation and some defecatory disorders. Normal transit means transit within the gastrointestinal lumen is normal, the transit frequency. Slow transit means the transit is slow, and defecatory disorder is there is some problems in the defecation. And there are some secondary constipation. Secondary means if there is some pathophysiology in the colon or rectum, if there is any drug use, most common drug that can cause severe constipation, example is opioid. Opioid induced constipation. There are different types of the anti-cancer drugs also that can also lead to constipation. So different drugs can lead to constipation. So this comes under the secondary constipation. Now how do you want to treat with the constipation? Firstly, the patient is to be advised different types of the lifestyle modifications. The most important is increased fiber intake, dietary fiber. You know that these dietary fibers can be soluble, can be insoluble, or it can be some synthetic fibers. Most commonly soluble dietary fibers are very much beneficial for the management of constipation. Now these dietary fibers may come from the diet, or we can supplement it by means of some drugs. So dietary fiber is commonly present in the fruits, nuts, seeds, whole grains, etc. So patient is to be advised to take these types of the foods more. The second lifestyle modification is increased hydration, increased fluid intake. The patient is to be asked to take more amount of the water. The third one is to decrease the amounts of the junk food, fast food, etc. All this can lead to increased constipation. The fourth one is some aerobic exercise like brisk walking, cycling, swimming, etc. This all leads to decrease in the constipation. Now this dietary fiber can be given as a drug. So dietary fiber drugs can be given. It should be started with a small amount and then gradually the dose can be built up, because if this dietary fiber is given in a large amount, that can lead to bloating, that can lead to abdominal discomfort. And if there is some obstructive disorder in the colon that leads to constipation, dietary fiber should not be given. Then other management should be optimized. So after this dietary fiber, there are different other drugs that can also be used for the treatment of the constipation. Now the first line drug is the different types of the osmotic drugs, osmotic laxatives or purgatives. Then there are some stimulatory laxatives or purgatives, and there are some newer drugs. We will discuss about this. So the constipation, already we have discussed how this constipation can be defined. There are different types of the definition, and the epidemiology of the constipation, you can say in the Asian population approximately 10 to 20% of the people are suffering from the constipation, but many of these patients are not treated because the patients are often hesitant to discuss their constipation problems with the doctors, and this constipation ultimately leads to decrease in the lifestyle, quality of the life. Similar like that, those persons who are suffering from the COPD or those persons who are suffering from the diabetes mellitus, like them, this is a chronic condition that needs some lifestyle modifications, that needs to take the drugs for a long period of the time. That's why the quality of life can be compromised. So the constipation has many reversible or secondary causes, as I have already discussed, like there may be lack of dietary fiber, there may be some use of the drugs that can lead to constipation, some hormonal disturbances may be there, neurogenic disorders can be there, and systemic illness. So you can see this is basically an infrequent production of the hard stool requiring straining or purse, a sense of incomplete evacuation. So feeling of the incomplete evacuation is the most common complaint that the patient will discuss with the doctors, that the evacuation is not complete. So this is the Rome criteria what I am discussing. So usually it is in short we can say that if the frequency of the defecation is less than 3 per week associated with different other symptoms like straining, presence of the hard stools, abdominal discomfort, incomplete evacuation for approximately 2 to 3 months, then we can say that the patient is suffering from the chronic constipation. So there are different brain gut hypotheses is there to discuss about this constipation. So we know there are beneficial colonic bacteria is there in our colon, and there is also neuron is there that controls this brain gut axis. So if there is some dyssynergy in this brain gut axis, if there is some changes in the microbiota in our colon, if that can occur due to usage of some drugs, for a long term antibiotic usage that can happen, if there is some obstructive problems, if there is some changes in the dietary habit, all this can lead to constipation. So you can see there are some behavioral disorders also, because it is some part neurogenic, this constipation part, like autism, attention deficit hyperactivity disorder, some psychological disorders like anxiety or depression can also lead to constipation. Lifestyle factors, already we have discussed about this. Obesity is an important factor for the constipation. Impaired anorectal function that can happen due to some pathophysiology that leads to constipation. Stress and stressful life events, like if there is some sudden stress, trauma or some abuse. Some parental factors like neuroticism, depression, overprotection, disrupted microbiota, genetic factors, colonic dysmotility, all this leads to dyssynergy between this brain and the gut. The neurons in the gut and the brain that controls. That leads to this problem, and this problems is more seen in case of the elderly person. It is more seen in case of the females rather than the males, like this. So primary constipation, secondary constipation. Primary constipation can be divided, already we have discussed, that may be normal transit constipation, slow transit constipation, or different types of the defecatory disorder that can also be classified as outlet obstruction types. And the secondary constipation, there are different drugs or diseases that leads to constipation. One of the most important thing that is associated with this idiopathic chronic constipation is the IBS constipation type. So irritable bowel syndrome constipation type, it ultimately overlaps with the chronic idiopathic constipation, and the treatment is more or less similar. So you can see primary constipation, normal transit constipation, mainly the patient complains with abdominal bloating and pain. Slow transit constipation, the bowel movement is less frequent. Outlet, there is problems in the outlet that may happen due to some delayed bowel movements, due to pain, defecation, there may be some hemorrhoids, there may be some anorectal fissure, etc. Secondary constipation, most common hormonal disorder is the hypothyroidism. Diabetes mellitus, because in diabetes mellitus there occurs usually gastrokinesis. So gastrokinesis ultimately leads to this type of problems. Diseases that affect the brain or blood vessels like dementia, depression, usage of the medications like opioid, chemotherapy, already I have discussed. Irritable bowel syndrome, constipation type. Inflammatory bowel disorders like Crohn's disease, ulcerative colitis, already I have seen. So all these are the secondary causes of the constipation. So how these gastrointestinal water and electrolytes are balanced? So water normally accounts for 70 to 85% of the total stool weight. So if there is decreased hydration or if there is decreased water in the stool, ultimately that leads to changes in the stool composition. Net stool fluid contents correct reflects a balance between the luminal input, that is what amount of the fluid comes into the lumen from the intestinal walls, and the output, that is the absorption along the length of the gastrointestinal tract. That is what amount of the water is absorbed back, what amount of the water is secreted into the lumen. The net balance ultimately determines the composition of the stools. Normally about 8 to 9 liter of the fluid enters the small intestine daily from the exogenous and endogenous sources. Net absorption of the water occurs in the small intestine in response to some osmotic gradients. So there are some gradients are present in the small intestinal wall. The result is uptake and secretion of the ions with only about 1 to 1.5 liter crossing the ileocecal valve. Okay. So the colon then extracts most of this remaining fluid, leaving about 100 milliliter of the fecal water daily. So under normal circumstances in physiology, these quantities are within the range of the total absorptive capacity of the small bowel. The total absorptive capacity of the small bowel is approximately 16 liter and in the colon less 4 to 5 liters. So these neurohormonal mechanisms, pathogens and drugs ultimately changes this composition, that is the secretion and absorption of the fluid from the intestinal wall. Altered motility also contributes in a general way to this process. That is, if the motility of the colon is decreased or if it is very much increased, ultimately, so with decreased motility or excess fluid removal, the feces can become insipated and impacted, that it becomes hard enough to be impacted within the colonic wall. So ultimately it is difficult to pass, so leading to constipation. So when the capacity of the colon to absorb fluid is exceeded, diarrhea occurs. That is just the opposite side of the constipation. So many of the approximately 60% of the persons with constipation have normal colonic transit. So colonic transit is normal, but there is problems in the secretion as well as the absorption of the colonic fluid. That leads to constipation in 60% of the patients. But in rest 40% of the patients, there may be slow colonic transit or there may be some irritable bowel syndrome constipation type. So less commonly an isolated disorder of the defecation or evacuation, like some outlet disorder, some problems in the outlet may happen due to dysfunction of the neuromuscular apparatus of the rectoanal region. So you can see this is the secondary causes of the constipation, like if there is some dehydration, if there is some immobility for a long period of time, decreased fiber diet, eating disorders, if there is some anorexia nervosa, bulimia nervosa, these are the eating disorders that leads to constipation. Some metabolic problems are there if there is increased calcium ion, hypercalcemia, if there is decreased magnesium like hypomagnesemia, decreased potassium level, hypokalemia or hypothyroidism. Hypothyroidism is very commonly associated with chronic constipation. Some neurologic disorder like there may be some multiple sclerosis, spinal deficits, cerebral palsy or cerebrovascular accidents like stroke. Obstruction like if there is some tumors in the outlet, if there is some strictures, fissures, hemorrhoids, all this can lead to problems. Some pharmacologic therapy, that is if we are using drugs for some other purpose and that leads to constipation. Like antipsychotic drugs, already we have discussed about the antipsychotics, that may lead to constipation. Tricyclic antidepressants, opioids, already we have discussed, calcium channel blockers, anticholinergics, antihistaminergics, iron supplements. When we are reading in the hematinics about the iron, we have discussed that many of the patients are suffering from the constipation in iron deficiency anemia if we are giving the iron. Calcium supplements, if the patient is suffering from the osteoporosis, we are giving some calcium, that also leads to constipation. Aluminum containing drugs, these are mainly used as antacids. So antacids contain aluminum containing drugs, that also leads to constipation, like antacids, already we have discussed. So these are the different common causes, secondary causes of the constipation. So apart from the secondary causes, the most of the cases, if there is no apparent cause, it is known as the idiopathic constipation or chronic idiopathic constipation. Okay. So you can see primary, there may be normal transit, it is the normal motility, but there is perceived difficulty in evacuation. So hard stools, bloating, response to usually fiber and osmotic laxatives. Primary but slow transit constipation is impaired phasic colonic motor activity and the transit is delayed. Here the patient complains with infrequent urges, severe bloating and resistant to basic fiber. primary, but if there is some pelvic floor dysfunction, that is also leads to dyssynergia between the coordination of the muscles that leads to evacuation of the stool. So the patient complains of prolonged straining of the feeling of the incomplete evacuation, and disinfection, manual disinfection is often required. Manual disinfection or giving some enema is often required. Secondary, like medication induced, already we have discussed. So we have to stop the medications, we have to give some other drugs. If there is some organic or systemic causes, we have to treat the disease. For example, if the patient is suffering from hypothyroidism, we have to treat the hypothyroidism like this. So drugs for the constipation can be divided into laxatives or purgatives. Laxatives, or also known as the adipyent, is usually of milder action. Elimination of the soft but firm stools can be done by giving the laxatives, while the purgative or cathartic is the stronger action, resulting in more fluid evacuation. What happens? Most of the drugs we will discuss today are falls under both laxative and purgative. So in the low doses, it acts as a laxative. In the high doses, it acts as a purgative. So in most of the cases, we are using laxative and purgative, these two terms interchangeably. Okay. So laxative means milder actions. In most of the cases, we use the term laxative, and purgative means if there is severe constipation, the same drug is to be given in a higher doses, we have to use this as purgative. So laxatives can be divided, like if it can be luminally active drugs, that is these drugs acts within the intestinal lumen. So that may be again subdivided into bulk forming drugs, osmotic laxatives, and some stool softener drugs. Bulk forming drugs are mainly the fibers. In the first part of my lecture, we have discussed about the dietary fibers. These dietary fibers comes under the bulk forming laxatives or bulk forming purgatives. So these dietary fibers increases the bulk of the stool by absorbing the water. So ultimately the volume of the stool is increased and it is easy to pass. So example of the bulk forming is the dietary fiber, bran, psyllium and methylcellulose. Different types of the dietary fibers, synthetic fibers like bran, cellulose, methylcellulose or psyllium. These are the bulk forming luminally active laxatives. Next is the osmotic laxatives. Osmotic laxatives now usually used as the first line drugs. If the patient is not responding to the dietary fibers, then we are using mainly these osmotic laxatives. Osmotic laxatives again can be divided into saline laxatives as well as the non-digestible sugars and alcohols. Saline laxative example is the magnesium sulfate, magnesium hydroxide and sodium phosphate. Magnesium sulfate, magnesium hydroxide and sodium phosphate. And non-digestible sugars and alcohols, the most common example is the lactulose. Lactulose is very commonly used. Apart from this, there is sorbitol, mannitol, and another most commonly used is the polyethylene glycol. These osmotic laxatives, most commonly this lactulose or polyethylene glycols, can be used in the elderly, can be used in the children, can be used in the normal patients as well as in the pregnancy. That's why it is very commonly used nowadays. Osmotic laxatives. So these are the osmotic laxatives example. The third part of the luminally active drugs is the stool softener. This softening of the stool is done by the surfactant actions. Example is the docusate or sodium docusate, liquid paraffin, different types of the mineral oils. So this comes under the surfactant or stool softener. Next, coming to the stimulant purgatives. So it ultimately stimulates the colonic transit and ultimately it acts as a purgative or laxative. Example is the bis-acodil, sodium picosulfate, phenolphthalein, some anthraquinone derivatives like senna, cascara, castor oil. So these stimulant purgatives are usually used as a short-term measure or as and when basis. If the patient is just suffering from the constipation infrequently and he is not responding to dietary fibers, then we can use this stimulant laxatives or stimulant purgatives. So these are the example of the stimulant laxatives or stimulant purgatives. Next, coming to some prokinetic drugs like 5-HT4 agonist like prucalopride. This is the newer drugs, prucalopride, newer drugs it can be used. Some D2 antagonists like metoclopramide, this is lesser used nowadays. Domperidone, some macrolide antibiotic like erythromycin. Some newer agents like chloride secretory agents like lubiprostone, linaclotide. Lubiprostone, linaclotide, these are the newer agents. Some opioid receptor antagonists like methyl naltrexone, albumin. Apart from this, there is some other newer drugs are also there. We will discuss about this. So this is the main classifications of the laxatives. So newer drugs, remember the names of the newer drugs like prucalopride, lubiprostone, linaclotide, albumin, methyl naltrexone, L-bixobat. These are the newer drugs. So first starting with the bulk purgatives or bulk laxatives, dietary fiber, most commonly different types of the dietary fibers. These are basically unabsorbable cell wall and other constituents of the vegetable food like cellulose, lignins, gums, pectins, glycoproteins and other polysaccharides. For example, bran. Bran is the residual product of the flour industry, flour, from which this industry there are some residual products flour that consist of approximately 40% of the dietary fiber. This bran can be used as a treatment for the constipation. It absorbs water in the intestine, ultimately swells, increases in the volume, increases water content of the feces, softens the feces and ultimately it facilitates the colonic transit. Osmotically active products may be formed in the colon by bacterial degradation of these pectins, gums, etc., which also retain water and ultimately the stool volume is increased. Dietary fiber supports the bacterial growth in colon which contribute to the fecal mass. So this dietary fiber on the one hand it absorbs water and increases the stool volume. On the other hand, the normal colonic bacteria also ferments this and ultimately that leads to different bacterial degradation products that also receives and retains more and more water. So increased intake of the dietary fiber is the most appropriate method for prevention of the functional constipation. So this constipation is a functional gastrointestinal disorder or functional bowel disorder. So the patient when comes with constipation, we should first counsel them about the lifestyle modifications and taking of the dietary fiber. We should prescribe about the dietary fibers first. There are different types of the bulk laxatives or purgatives and dietary fiber. So these are the different types. So it is the first line approach for the most patients of the simple constipation, first line approach. Prolonged intake of the bran and other bulk forming agents reduces the rectosigmoid intraluminal pressure and helps to relieve the symptoms of the irritable bowel syndrome also and constipation as well as the diarrhea, all these. So in case of the irritable bowel syndrome, already you have seen that some patients are suffering from the constipation type, but in the midst of this there may be diarrhea. So there may be cyclical constipation and diarrhea in irritable bowel syndrome. These are also will be benefited from these bulk purgatives. Symptoms of the chronic diverticulosis may also be relieved. It is also useful when straining at stools has to be avoided. So bran is usually safe. It is unpalatable, large quantity needs to be ingested usually. So you can see bulk formatting laxatives increases the fecal mass by absorbing water leading to the peristalsis. So when the fecal mass is increased, ultimately the colonic transit time will be increased and ultimately there will be more frequency and there will be leading to more peristalsis. So examples fibrogel, methylcellulose, bran, etc., etc. So these are the bulk forming laxatives. The green one are the bulk forming laxatives. Okay. So they act within 12 to 24 hours. Psyllium and Isabgol herbs, these are also bulk purgative, most commonly used. They contain natural colloid mucilage which forms a gelatinous mass by absorbing water. It is largely fermented in colon, increases bacterial mass and ultimately softens the feces. Isabgol herbs very commonly used, many elderly persons 3 to 8 gram freshly mixed with cold milk or fruit juice or water, usually to be taken once or twice daily. It usually acts in 1 to 3 days. It should not be swallowed dry. So Isabgol herbs or bran or methylcellulose, it should be mixed with milk or water or fruit juice. Usually the patient is asked to take it at bedtime. If there is more constipation, it can be taken twice daily, in the noon as well as in the bedtime. Methylcellulose is basically a semi-synthetic colloid and hydrophilic derivative of the cellulose that remains largely unfermented in colon. So these are different other bulk purgatives. So after the bulk purgatives, next luminally active laxative is the stool softener. Stool softener example is the docusets. This is the full form is the dioctyl sodium sulfosuccinate. Dioctyl sodium sulfosuccinate is a stool softener which is basically an anionic detergent, softens the stool by the net water accumulation in the lumen by an action on the intestinal mucosa. Basically they have some surfactant like action, that is why they are known as the detergent. Okay. It emulsifies the colonic contents and increases the penetration of water into the feces. More water is penetrated because it reduces the surface tension between the intestinal wall as well as the stool mass. By a detergent action, it can disrupt the mucosal barrier and enhances absorption of many non-absorbable drugs also, like liquid paraffin. So it should not be combined with it. So usually we need these drugs within the colon. It should not be absorbed. So it should not be mixed with other laxatives. It is a mild laxative usually indicated when straining at stool must be avoided. So you can see how the stool softener acts. So decrease stool surface tension. So when the stool softener is given, the smaller ones, they decreases the surface tension so that it will not be impacted within the intestinal wall. So water penetrates and mixes with this fecal matter and ultimately the stool is softened. So active ingredient is the docusate sodium, anionic surfactants used to soften fecal matter. So the same thing, it decreases the surface tension between the water outside the stool and fat in the stool. So this results to water penetrating and mixing with fecal matter and leading to the softer stools, generally produces a bowel movement in 12 to 72 hours. So it allows passages of the stool without strain, and adverse effect is usually diarrhea. Usually the adverse effects of all these anti-constipation agent is diarrhea. So this is by how the stool softeners act. Next, coming to the stimulant purgatives. So these are the powerful purgatives. If it is used for a long period of time, that leads to electrolyte disbalance. So hence it is to be used as and when basis if there is for a short period of a time. They irritate the intestinal mucosa and thus were thought to primarily stimulate motor activity. So basically they increases the motor activity. Accumulation of the water and electrolytes in the lumen by altering absorptive and secretory activity of the mucosal cells. They inhibit the sodium potassium ATPase at the basolateral membrane of the intestinal wall. So transport of the sodium and accompanying water into the interstitium is reduced. So ultimately secretion is enhanced by activation of the cyclic AMP in the crypt cells and by increased prostaglandin synthesis. So basically they act to second messenger system of the cyclic AMP to increase the sudden increase of the water within the colon. The laxative action of this bis-acodile or cascara, these are the stimulant purgative, is shown to be partly dependent upon the increased nitric oxide synthesis or action in the colon. So ultimately nitric oxide causes the vasodilatation, and that is also helpful in relieving the constipation. Larger doses of the stimulant purgatives can cause excessive purgation, resulting in fluid and electrolyte imbalance. So the stimulant purgative should not be used for a long period of time because there may be some dyselectrolytemia. Okay. It can reflexively stimulate gravid uterus also. That's why it should not be used in pregnancy. So you can see by which the stimulant laxative acts. Example is the cascara, aloe, senosides, bis-acodil, picosulfate, castor oil. Castor oil is previously used in case of the children, but because of this dyselectrolytemia, severe colonic movement, sudden severe colonic movement, it is lesser used nowadays. So ultimately they decreases the absorption of the water back to the intestine, increases the motility and increases the prostaglandins levels. They increases the nitric oxide level, increases the pain, we need sudden purgatives. For example, we need the sudden purgative for 1 or 2 days due to some investigation purpose. So here we can use the stimulant purgative. Main side effects is the cramping, because there is increased colonic motility, sudden increased colonic motility. So there may be some abdominal cramps, there may be bloating, borborygmy, diarrhea, that is bloating, severe bloating can happen. So this is the way by which the stimulant laxative acts. B-Sacodyl, they are partly absorbed and resecreted in bile. B-Sacodyl is activated in the intestine by deacetylation. The primary site of action of this diphenyl methanes is in the colon. B-Sacodyl is a stimulant purgative. 1 or 2 semi-formed motions occur after 6 to 8 hours. Okay. So morphologic alterations in colonic mucosa have been observed. That's why it should not be used for a long period of time. Mucosa becomes more leaky. That is, in the long period of time, that ultimately leads to chronic diarrhea also if we are using for a long period of time. Allergic reactions can happen with this bis-acodyl. Sodium picosulfate is another diphenyl methane, another stimulant purgative. It is hydrolyzed by colonic bacteria to the active form, which then acts locally to irritate the mucosa and activate the myenteric neurons. So this is the enteric nervous system. So basically they are stimulating the enteric nervous system like in the myenteric plexus. Along with the magnesium citrate solution, it has been used to evacuate the colon for colonoscopy and colonic surgery. So you can see if there is some colonic surgery or if we are to do some colonoscopy, before that we have to evacuate the stools that is already present within the colon. So for this short period of time before this diagnostic procedure, we can use the stimulant purgatives like this bis-acodyl, sodium picosulfate, etc. etc. Senna is another one. It is obtained from the leaves and the pods of the certain cassia species. Cassia is a plant, Cascara sagrada. So ultimately from these different glycosides are obtained. Example is imodins. The purgative action and the uses of these anthraquinones are quite similar to that of the diphenyl methanes. Diphenyl methanes example is the bis-acodyl, already you have seen, and these are obtained from the different senna or different plants of the cascara. So usually it is taken at bedtime. Single soft but formed evacuation generally occurs in the morning. Cramps and excessive purging occurs in some individuals. This is similar to all the different types of the stimulant purgatives. They also promote secretion and inhibit salt and water absorption in the colon. Next, coming to a newer drug known as the prucalopride. Prucalopride is a selective 5-HT4 receptor agonist. 5-HT4 receptor is present. They are selectively agonism of this receptor for the treatment of mainly the chronic idiopathic constipation as well as the irritable bowel syndrome constipation type, where the other laxative fails. So we are using some dietary fibers, different types of the dietary fibers, osmotic ones, etc. etc. If it fails, then we can give some prucalopride. So it activates some pre-junctional 5-HT4 receptors on intrinsic enteric neurons to enhance the release of the excitatory neurotransmitter acetylcholine. So basically they increase the release of the acetylcholine. Ultimately that promotes propulsive contractions in the ileum. This acetylcholine acts on these myenteric neurons. They ultimately causes the increased contraction in the ileum and increased contraction in the colon. Recommended dose is 2 mg once daily in the adults and 1 mg daily in individuals with severe renal impairment. The most frequent generally transient side effects are the headache, abdominal pain, nausea and diarrhea. So this is how the prucalopride acts. So mainly target the 5-HT4 receptors, remember. So they are thought to stimulate 5-HT4 receptors on the intrinsic sensory neurons. So intrinsic sensory neurons, these neurons are present within the enteric nervous system, within the gut walls. They mainly attaches with these 5-HT4 receptors and causes agonism. So that ultimately when this agonistic activity happens, there will be more release of the acetylcholine. This acetylcholine leads to more contraction of the ileum as well as the colon. So triggers peristaltic reflex and colonic mass movement. So you can see by which that leads to more complete evacuation of the stools. So this way the prucalopride acts. So they mainly acts in the 5-HT4 receptor agonism. Next, coming to the osmotic purgatives or osmotic laxatives. These are very commonly used nowadays as a first line therapy. These are the solutes that are not absorbed in the intestine. They retain water osmotically and distend the bowel. Ultimately, when the bowel is distended, the nerves are activated, so there will be peristalsis. Magnesium ions release the cholecystokinin also, which augments the motility and secretion and contributes to the purgative action of the magnesium salts. Example is the lactulose. Lactulose is a semi-synthetic disaccharide of fructose and lactose, which is neither digested nor absorbed in the small intestine. So it is not digested nor absorbed in the intestine, it is present within the intestinal lumen. So ultimately they retains water because they are osmotically active. It is broken down in the colon by bacteria also to osmotically more active products. In patients with hepatic encephalopathy, lactulose causes reduction of the blood ammonia levels by approximately 25 to 50%. The breakdown products of the lactulose are acidic. So ultimately they lowers the pH of the stools. Ammonia produced by the bacteria in colons is converted to ionized ammonium, that is the NH4 salts that are not absorbed. So that's why in hepatic encephalopathy, where there are changes in the bacteria level happens, when we are using this lactulose, they not only relieves the constipation, that also changes the ammonia that is produced by this bacteria in case of the hepatic encephalopathy to ammonium ion, that is ultimately that relieves the hepatic encephalopathy. So lactulose is a osmotic laxative or osmotic purgative. So you can see how the osmotic laxatives act. So osmotic laxatives, when it is given, they remains within the intestinal lumen, they are not digested, they are not absorbed, they are osmotically active particles, so they causes the increased osmotic pressure. So when it comes, that leads to increased fluid and electrolytes in the lumen, that leads to water incorporation into the stools, softening of the stools. When the softening of the stools occurs, they also leads to increased peristalsis, so the colonic transit will be increased, so ultimately the bowel evacuation happens. So this is the way by which the osmotic laxatives acts. So bulk forming laxatives mainly increases the bulk of the stools and ultimately that leads to more evacuation. Stimulant laxatives ultimately stimulates the nervous system to increase the colonic motility and ultimately causes the evacuation. Stool softeners softens the stools and ultimately leads to more evacuation, and these osmotically active ones are the basically they are osmotically active particles. Osmotically active means there is presence of the osmotic gradient, they absorbs more and more water and ultimately the end result is the same in normal and increased stool evacuation. There is another drug that is very commonly used as osmotic laxative is the polyethylene glycol. Polyethylene glycol, long chain polyethylene glycol approximately 4000 kilodalton are poorly absorbed and they are retained water via their high osmotic nature. The osmotic nature is quite high, that's why this is very commonly used. When used in high volume, aqueous solutions of these polyethylene glycols with electrolytes produce an effective catharsis. That is the effective, it causes a more effective purgative action, have replaced the oral sodium phosphates as the most widely used preparations for colonic cleansing before some radiological procedure, before some surgical procedure or before some endoscopic procedures. Even in case of the pregnancy, you know, in case of the pregnancy there may be constipation, that may be severe constipation in some of the cases. In pregnancy, in constipation, also now the main choice of the drugs is the osmotically active laxatives, most commonly this high molecular weight polyethylene glycol. So polyethylene glycol can be used for constipation in case of the pregnancy. To avoid the net transfer of the ions across the intestinal wall, these preparations contain an isotonic mixture of the sodium sulfate, sodium bicarbonate, sodium chloride and potassium chloride. That's why there will be no dyselectrolytemia, that is quite common with the other agents. The osmotic activity of the polyethylene glycol molecules retain the added water and the electrolytes concentration causes little or no effect of ionic shifts. That's why there will be no hypomagnesemia, no hypokalemia or hyponatremia when we are using the polyethylene glycol. Next one is the lubiprostone. Lubiprostone is another newer drug that is used for the constipation if it fails the other therapies already we have discussed. So basically it is a bicyclic fatty acid that is derived from the prostaglandins E1 that increases the intestinal chloride secretion by activating the type 2 chloride channels on epithelial cells. On the epithelial cells there are CFTR chloride membranes, chloride ions are synthesized from this. So when we are using this type of the drugs, that increases the chloride ion synthesis and that ultimately leads to more water absorption. So this is approved for the treating of the chronic idiopathic constipation as well as the irritable bowel syndrome with constipation at a dose of 24 microgram 2 times daily or 8 microgram 2 times daily in case of the irritable bowel syndrome. It improves stool frequency and consistency as well as abdominal discomfort and bloating, which is a bothersome symptom in case of the chronic idiopathic constipation. So ultimately it accelerates the small intestinal and colonic transit. It can be taken with meals. It contraindicated in individuals with known or suspected mechanical gastrointestinal obstruction. So if there is obstruction is there, these drugs will not act because there is already obstruction. So we need some surgical procedures there. Observed in 35% of the individuals, nausea may be present. So nausea is the most common side effect of the lubiprostone. So this is the way by which the lubiprostone acts. So lubiprostone mainly activates the chloride channels. These chloride channels are present on the intestinal walls known as the CIC2. So when this lubiprostone is given, they attaches with the CIC2 channels. Ultimately that leads to more sodium and chloride release. Mainly the sodium and chloride leads to more absorption of the water within the gut lumen. So ultimately softening of the stool happens, the bowel movement is improved. That ultimately relieves the constipation, improves the bowel frequency. So it acts locally, minimal systemic absorption happens, relieves constipation and improves bowel frequency. So ultimately the softening of the stool and improved bowel movement is the end result of using this lubiprostone. So lubiprostone, how it acts? It attaches with the CIC2, which is a receptor, which is a channel present on the intestinal wall and thus increases the chloride ion. The main function is the increase of the chloride ion in the intestinal lumen and that leads to more water accumulation within the gut wall, gut membrane. Next, another newer drug is the linaclotide. Linaclotide. It is a guanylate cyclase C agonist. Guanylate cyclase is another second messenger system. This is approved for the treatment of the chronic idiopathic constipation, 72 microgram or 145 microgram daily. 290 microgram higher dose is usually needed for the idiopathic when there is some irritable bowel syndrome constipation type is present. Its effect on the abdominal discomfort, pain and bloating, it may be useful in individual with these coexisting symptoms. So when the constipation is associated with more abdominal discomfort or bloating, we can use this linaclotide. It can be taken without food at least 30 minutes before the first meal of the day. So lubiprostone is to be taken with meal, but linaclotide is to be taken before meal, approximately 30 minutes before meal time. It is contraindicated in individuals with known or suspected mechanical gastrointestinal obstruction similar to the before ones. Might be associated with diarrhea leading to discontinuation or dose reduction. This is not very common. So this is how the linaclotide acts. So basically this is a guanylate cyclase C agonist. So guanylate cyclase, when the linaclotide is given, the guanylate cyclase, again this enzyme is present within the gut wall, within the intestinal wall. This attaches with this. Ultimately there will be more conversion of GTP to cGMP and ultimately this cGMP, this blocks the apparent pain fibers and ultimately there will be less sodium and chloride release. So when this linaclotide is given, there will be ultimately the end result is the more sodium release, more chloride release within the gastrointestinal lumen. Sodium chloride, you know, ultimately takes up more and more water. So there will be more stool evacuation, easier stool evacuation. So this is the way by which the linaclotide acts. So basically this is a guanylate cyclase C agonist. Plecanatide. Plecanatide, it is a pH dependent guanylate cyclase C agonist. more or less similar, but the newer ones like that of the linaclotide, it is approved again both for the chronic idiopathic constipation as well as the irritable bowel syndrome with constipation type. Dose is 3 mg daily taken with or without food. It increases again the cyclic guanosine monophosphate concentration. Ultimately, the similar way, it increases the luminal chloride, luminal bicarbonate secretion, thereby increasing the intestinal fluid and accelerating the gastrointestinal transit. So, linaclotide and this pleclanatide, the more or less they act similarly. Basically, they are guanylate cyclase C agonist. So, the end result of this agonism with the guanylate cyclase is the increased cGMP, and this increased cGMP causes increased chloride release, increased sodium release, increased bicarbonate release within the gastrointestinal lumen, and all this leads to more water retention within the stools. This is another neurogens, is the peripherally acting mu opioid antagonist. So, methyl naltrexone, albumin and naloxegol. These are very lesser used in many refractory cases, most of the cases when there is some cancer or the patient is suffering from cancer or cancer chemotherapy, there is severe constipation, we can use this peripherally acting mu opioid antagonist. So, methyl naltrexone is basically administered subcutaneously and is effective for opioid induced constipation in palliative care. For example, if there is severe cancer pain, we have to give the morphine. And already in the opioid class, you have seen that this morphine or the other opioids causes severe constipation. So, we can give these types of the mu opioid receptor antagonist in them in case of these patients with palliative care. It should not be used in patients with intestinal obstruction and should be used with caution in patients with intestinal malignancy. Albumin is again used short-term treatment of the postoperative ileus, is available only through a restricted prescribing program because of increased risk of myocardial infarction. So, if there is some colonic operation or if there is some gastrointestinal operation, after operation there may be dysmotility of the colon. This is known as the ileus. So, postoperative ileus. So, in those cases we can use the albumin. Albumin is normally not used for the management of the constipation, only in selected cases. Naloxegol. Naloxegol is administered orally and again it is approved for opioid induced constipation in patients who do not have cancer. So, mainly these are used in case of the opioid induced constipation or those patients who are suffering from the cancer or those patients who are taking the chemotherapy and they are suffering for severe constipation refractory to all this therapy beforehand. There may be probiotics. Probiotics may be used to increase the health of the normal commensal colonic bacteria, but they are not the first line or second line treatment for the treatment of the constipation. But for the long period of the time, if the patients are suffering from the chronic constipation, we can add on these probiotics as well as the prebiotics. Like they are modulate gut microbiota, like this beneficial and commensal bacteria, most commonly like lactobacillus. They improve the intestinal barrier function and bowel movement, like increase the tight junctional proteins, increase motility and increase mucin secretion. They release constipation, increase defecation frequency like fecal biomass and fecal moisture content. All this can be improved. So, probiotics are not the first or second line therapy, but this can be as an add-on therapy for a long period of time. If for example, the patient need not take the laxatives for a long period of time, but we can use in the mid of the time when the constipation is not so severe, the probiotics. Apart from this, there are some newer other agents are there, like there is one drug known as the Ilobixibat. Ilobixibat is the latest one. Ilobixibat basically increases the bile acid secretion within the colon. Ilobixibat, Elobixibat. Ilobixibat can be used when we are using in case of the chronic idiopathic constipation or irritable bowel syndrome with constipation type. Here it mainly increases the bile acid by blocking the different transporter that absorbs the bile acids. So, ultimately the end result is the more bile acid secretion from the liver, and these bile acids are more available within the intestinal lumen, and these bile acids ultimately leads to more softening of the stools and there may be easier defecation. So Isabgol is the newest one. So the newer ones already we have discussed about the prucalopride. Remember prucalopride? We already discussed about the lubiprostone. We have already discussed about the linaclotide, and we have discussed about the Isabgol. Okay. So now coming to the contraindications of the laxatives. So our patients of undiagnosed abdominal pain, colic or vomiting, you should not give the laxative beforehand because there may be some mechanical obstruction. So here we have to treat the mechanical obstruction. Okay. If there is some organic or secondary constipation, so we have to ask the patient if the patient is suffering from some other diseases. There may be some hemorrhoids, anorectal fissures, there may be some hypothyroidism, there may be some diabetic gastrokinesis. All these needs to be treated first. Hypothyroidism, hypercalcemia, there may be malignancies, etc. Certain drugs, if the patient, you have to inquire if the patient is taking some drugs, like most commonly some opioid drugs, some cancer chemotherapeutic drugs, the patient if there is some antipsychotic drugs or tricyclic antidepressant drugs, some calcium channel blockers drugs like this, some clonidine, if the patient is taking oral iron. So when the patient is complaining of constipation, you should inquire what the patient is taking any drugs of these classes or not. So accordingly we have to proceed. Verapamil. Verapamil is another calcium channel blocker which is very notorious for causing the constipation. Verapamil. And laxative abuse is also another problem because these laxatives or purgatives are available over the counter in our country, in some of the foreign countries also. So the patient is also not aware of what is the actual constipation is. So even if there is a minute straining in the stools or there is a minute constipation for 1 or 2 weeks, the patient may start taking some laxatives. And if the patient is taking laxatives for a long period of time, if there is some laxative abuse, it is known, ultimately there may be some resistance to the use of the laxatives because there may be more changes in the electrolytes, there may be changes in the normal commensal bacteria within the guts. So there may be some laxative abuse or laxative resistance. There may be severe diarrhea also. So you also have to inquire about this. So the indications of the laxatives, the first or foremost is the functional constipation. There may be some spastic constipation, like there may be some irritable bowel. Here the stools are hard, rounded, stone-like and difficult to pass. So you can see that there are some Bristol stool chart is there. So there are different forms of the stool, Bristol stool chart. The patient can be given this stool chart. This is known as the Bristol stool chart, and accordingly the patient can say what are the types of the stools they are having, and accordingly you can categorize this. So usually we can use some osmotic laxatives or we can use some bulk forming laxatives. These are the first line drugs. Stimulant pharmaceuticals are usually contraindicated when there is some irritable bowel. There may be already there is increased motility within the colon, but there is constipation. We should not use the stimulant purgatives. But if there is atonic constipation, that is the colonic motility is very less or atonia is there, mostly due to advanced age. This is more common in case of the elderly persons or debility or laxative abuse. So non-drug measures like plenty of fluids, exercise, regular habits, reassurance would be tried. So in many of the cases we need some psychotic therapy, behavioral, cognitive behavioral therapy is to be given. In some of the cases some biofeedback therapy, it is known as biofeedback therapy. It is to be given in those patients who are suffering from the constipation. There are different types of the device is also there, like there may be some vibratory capsules that can be ingested that leads to more colonic motility if it is causing by means of the vibration within the colon. There may be some nerve stimulation interventions are also there, like there may be some percutaneous tibial nerve stimulation or sacral nerve stimulation can be there in refractory cases of the constipation. In resistant cases, bulk forming agent can be given. In case of the poor compliance or patient is not satisfied, bisacodyl or senna may be given once or twice. So if the patient is already taking some bulk forming or osmotic laxatives, and again in some days there may be severe constipation, then we can give some stimulant laxatives. And if it fails, if the patient fails with the osmotic laxatives, if the fails with the bulk laxatives and stimulant laxatives, then we can give the newer ones, like we can give the prucalopride, linaclotide, lubiprostone, or we have already discussed about the Isabgol. we can give. If they are not again controlled, then we can give the cognitive behavioral therapy, biofeedback therapy, psychotherapy, different other device therapy, etc. etc. Bedridden patients, very common, myocardial infarction, stroke, fractures, etc. Here the bowel movement is sluggish, constipation may be there. To prevent constipation, we can use this bulk forming agents or docusets, lactulose can be given. To treat constipation, in severe constipation, if that needs some enema or manual extraction, we can give the enema in some of the cases. To avoid straining at stools, if the straining is contraindicated, like if there is some hernia, the patient is suffering from hernia, if there is some cardiovascular disease, if there is eye surgery, we can give some laxatives. That the patient should not strain while defecating, because that can cause the problems. If the preparation of the bowel for the surgery, colonoscopy, abdominal X-ray, ultrasonography, etc. So these drugs are not only used for the treatment of the constipation, it can be used before some diagnostic procedures, it can be used before some operations also. Okay. After certain anti-helminthic drug, so if there is some helminthic infestation, so we are giving anti-helminthic drug. With this, we have to give the laxative so that the helminths that is already present within the colons, that is already died by means of the anti-helminthic drug, that will be evacuated completely. Food or drug poisoning, again, if the poison is already present within the gut, we have to get rid of these poisons as soon as possible. So we can use some catharsis, we can use some purgation by this. Usually the saline purgatives are used. So the choices of the purgative depends on the latency of the action and the types of the stools. Like soft formed feces, usually 1 to 3 days is usually required when we are using bulk forming docusets, liquid paraffin or lactulose. Semi-fluid stools usually take 6 to 8 hours, usually done when we are using some stimulant laxatives like bisacodil, sodium picosulfate, senna, phenylephrine, etc. And watery evacuation, total water evacuation, diarrhea like within 1 to 3 hours can be obtained when we are using castor oil or saline purgatives. Okay. So purgative abuse or laxative abuse, what I am telling, abuse is very common in our country also. Some individuals are obsessed of using purgatives regularly, maybe due to psychological problems. Again, there may be some psychological problems like anorexia nervosa or bulimia nervosa. Here is also there will be purgative abuse. Obtained ultimately, chronic use of the purgative should be discouraged. Once the purgative habit forms, it is difficult to break. So if the patient is totally dependent on the purgative for the evacuation, it is difficult to break. Dangers of the purgative abuse are flaring of the intestinal pathology, rupture of the inflamed appendix can happen, fluid and electrolyte imbalance, especially hypokalemia can happen, steatorrhea, that is more fatty stools can happen, malabsorption syndrome can develop because the colonic microbiota will be changed, there will be dyssynergy, protein losing enteropathy can happen and spastic colitis can happen. So these are the problems of the chronic purgative use without consulting with the doctors. So this is also very common, remember this. So the management of the chronic constipation, the same thing already we have discussed. So for normal transit constipation, we have to first educate the patients about the dietary habits, about the exercise, lifestyle modification and more fiber supplementation. Second line of options is the osmotic laxatives, saline laxatives, chloride channel activators, tegacerol, etc. Slow transit constipation, we should start with the osmotic laxatives, saline laxative, some rescue treatment. Rescue treatment is always with the stimulant laxatives like bisacodil, senna, etc. But we can also use some osmotic ones like polyethylene glycol, enema. When the manual extraction is needed, it is not evacuated. Second line option is we can maximize the dosing, use the combination therapy from the different pathophysiology. Dyssynergic defecation, when there is some defecation disorder, we can use the suppository or enema, osmotic laxatives or saline laxatives, and we can give some biofeedback therapy, we can use some surgery, etc. etc. So these are the steps by which the laxative use usually needed, like lifestyle modification, behavioral therapy, laxative therapy. Then we need some rectal evacuation, physiotherapy, biofeedback, neuromodulation and surgical intervention. So mainly in most of the patients usually relieved with this. If they are not relieved, then we need this psychotherapy, biofeedback, neuromodulation, etc., etc. So this is all about the pharmacotherapy of the constipation. Thank you.